very much. We're pleased to have a very special guest joining me right now. This is Dr. Rache Simmons, Chief of Breast Surgery, New York Presbyterian and Weill Cornell Medicine. Thank you so much for being here, Dr. Simmons. Great things are happening, a 40% reduction in the death rate, saving 322,000 lives. This is all good news.
All good news.
Good news. And you're part of that. There are a lot of advances. Tell us about some of the new treatment and the good things that you're seeing.
Well, I think the first important thing is we're finding breast cancer earlier. The screening technology has gotten so much better. In particular, this tomo or 3D mammography, we're able to see very tiny tumors in very dense breast tissue. We couldn't do that 10 years ago. So we're finding cancer earlier. Then we're actually able to give patients much better chemotherapy drugs, those that need chemotherapy. So instead of a shotgun approach, it's a magic bullet. It goes right to the tumor. This is
targeted treatment, as they call it, right?
Targeted treatment, exactly.
Yes.
Exactly.
Makes a big difference, too, doesn't it?
Huge difference.
With everything.
We're actually finding patients where the cancer completely melts away without any kind of surgery. It's incredible. And
with chemotherapy and radiation as well, I mean, it's just a shorter regimen as well, right?
Absolutely. If patients have a lumpectomy, they also typically need to have radiation, but radiation can be given in different ways. And one of the ways that we're offering patients to have radiation is often a very short dose, maybe a week or two, not the 5 or 6 weeks they would have had traditionally. And as well, we can target just the area of the breast that has the cancer, not the whole breast of healthy tissue. There's no reason to radiate healthy tissue. So it's a much better regimen, less toxic for the patient, and equal outcome.
There are a lot about genetic testing these days, and tell us more about that, and who would be a good candidate for that? How does that work?
Well, genetic testing tells us if you have a very high risk of either developing breast cancer or if you already have breast cancer, of having another breast cancer. So it really depends upon the family history and the age of diagnosis. So if someone comes in at age 80 who has breast cancer and no family history, they really wouldn't be an appropriate person to have genetic testing. Very, very likely they're going to be positive. Versus somebody who comes in who's 35 with breast cancer, whose mother had breast cancer, whose aunt had breast cancer, grandmother had breast cancer, maybe some ovarian cancer. That's a person to be tested, whether they really would be positive or not.
Okay, we've seen so much progress, so many advances that you just outlined for us, and much more. What do you see in the next 5 years and in the future? What's it going to look like?
Well, I think we're doing a lot less surgery for breast cancer. I think they'll be able to be found earlier, again, with great screen technology. Then they'll have some sort of an image-directed needle biopsy. With that tiny piece of tissue from the tumor, they will then have a myriad of testing that will be done on the tumor cells. That will tell us a lot about prognosis, a lot about whether or not they even need chemotherapy. If they do need chemotherapy, what kind would be best to really cure their cancer.
Boy, this is all very, very promising, Dr. Simmons. Thank you so much for joining us today, okay?
It's a pleasure.
Come back with more good news.
Thank you.
Thank you. All right, coming up here, you